Thank you very much. Good morning. We're going to talk about bladder cancer in the elderly, and the objectives of my talk is review changing demographic of patients with bladder cancer as the general population ages. Then we will review treatment outcome of geriatric patients with muscle-invasive and non-muscle invasive bladder cancer in comparison to non-geriatric patients, and then review clinical tools for assessment of geriatric patients undergoing oncologic treatment. So let's talk a bit about bladder cancer. As you know, in US, each year we will see 70,000 new cases of bladder cancer, 14,000 deaths attributed to the bladder cancer, 500,000 bladder cancer survivor right now, and 9 out of 10 of them are at the age of 55 or more, and the average age at the time of diagnosis is 73. If we look at the median age of all cancers, it's interesting that bladder cancer is kind of the oldest cancer. So if you look at colon cancer, the median age is 71, prostate cancer 67, and bladder cancer is 73. The other way to look at it is if you compare the ratio of patients who are more than 65 as opposed to the patients who are less than 65, you will see that in bladder cancer the ratio is 70% to 30%. It is the same in kidney cancer, 50-50, and then in prostate cancer the ratio is 60 to 40. So bladder cancer is actually a disease of the elderly, and it's the same in different ethnicities, although we will see more bladder cancer in Caucasians. Interestingly, this is a very interesting graph. We will come back to it later. So low-risk prostate cancer, non-muscle invasive, high-risk prostate cancer, bladder cancer, non-muscle invasive, and then muscle invasive bladder cancer. You see as the age is getting higher, you will see more all-cause mortality and bladder cancer specific mortality. So black is bladder cancer specific mortality, and gray is other cause mortality. So you will see that in the patient at the age of more than 80, we have more mortality in this group of patients. So what about the population? In 1950, just 5% of population was over the age of 65. It is 21% in 2007, and it would be 40% in 2050. And if you look at the numbers in US, 30 million people in 2000 was over the age of 65, which would be 65 million people at 2050. What about Canada? In 1981, 2.4 million people actually were at the age of 65. In 2000, the number increased to 3.8 million people. Right now, 1 out of 8 Canadians is actually a senior, and in 2026, it would be 7.7 million, and we would have 21% of population as a senior, so 1 out of 5. And if you look at the world, in 2002, you will see that if you look at the pink as the ratio of population more than the age of 20, more than the age of 65, and if it is more than 20%, it's in pink or purple. You will see that in 2002, it was just part of Europe, but in 2050, it would be almost all the world, including Caspian Sea. So we will expect a silver tsunami, which is coming toward us. Great tsunami. Yeah. So advancing medical care and increase in life expectancy is a fact. The percentage of persons age 85 and more is actually estimated to be more than doubled by the year of 2050, and bladder cancer is actually a disease of elderly with peak incidence rate occurring at 85. So what are the options for treatment? Let's talk about non-muscle invasive bladder cancer. So 83-year-old male with hypertension and CAD comes to you with microscopic hematuria, smoked 40 pack a year, quit 15 years ago, mentally fit, lives in assisted living facility, positive cytology, normal CT-IVP, and the bladder biopsy showed CIS. So we will think about intravesical therapy, but what about the results? So good work by Judy et al. Actually published in 2006 in Journal of Urology, looked at patients with superficial bladder cancer, 400 of them treated with BCG plus interferon. Interestingly, they found a difference in response rate between the group of patients at the age of 61 to 70 as opposed to patients at the age of 80, and they concluded that aging appears to be associated with decreased response to intravesical therapy, especially in the patient at the age of 80 and more. And the potential explanation by them is that it could be because of depressed baseline immune status or inability to mount an immune response to intravesical therapy. And this is the multivariable analysis table, which actually looked at age, stage, prior BCG therapy, and multifocality as factors predicting the response to BCG. But their endpoint is cancer-free survival and recurrence-free survival. Another single-author paper by Dr. Harry Herr looked at age out and the outcome of treatment in BCG treatment. Actually, he found no difference after 2 years in cancer-free survival, but actually after 5 years, he realized that there is a difference between the group of less than 70 and more than 70 in response to BCG. And this is his multivariable analysis table, looked at sex, multifocality, age, prior BCG therapy, and restaging after 2R as an independent predictors of response to therapy. But his endpoint was cancer-free survival. The other work from Toronto actually looked at progression-free survival, and they compared the progression-free survival after BCG therapy between the group of age of less than 75 and more than 75, and they found that there is a difference in response rate, 87% versus 65%. And interestingly, they just found age and maintenance therapy as a predicting factor for progression-free survival. So no difference in recurrence-free survival, but difference in progression-free survival. And then EORTC study published 2014 October looked at 800 patients, randomized them to BCG, epirubicin, BCG, and isoniazid in the 3 different arms, and they didn't include any CIS, TA, and T1. And they looked at age in a different way, less than 70 or more than 70, and then as a continuous variable. So there was no difference in between 2 groups in recurrence rate, but there were difference in progression-free survival, overall survival, and deaths from bladder cancer. So they concluded that in intermediate and high-risk TA-T1, patients with the age of 70 and more have a worse long-term prognosis. However, BCG is more effective than the other way of treatment, including epirubicin. And then Gomez et al. Actually added age to this previous nomogram for prediction of recurrence and progression in non-muscle invasive bladder cancer. So based on what I showed, one might conclude that BCG is less effective in the elderly because of waning immune system. And then the prompt question would be, should we direct elderly patient away from BCG? But I would say I see it differently. If we look back at the table, at the graph that I showed, you see that in low risk and high risk bladder cancer, non-muscle invasive, when the patient getting older, you will see less survival. And then if we look at the study that I showed, all of the endpoint was kind of survival. So I would say, yes, the prognosis is worse in the elderly patient, but I don't think BCG is less effective in this group of patients, and we need more study to make it clear. What about muscle invasive bladder cancer? So 87-year-old male, stage 3, past medical history of CAD, COPD, prostate cancer, radiotherapy. He is widowed, independent in ADL and IADL. Hemoglobin 12.6, albumin is 4.5, creatinine 123. You are considering radical cystectomy for him, but family concerned about complication risks, maintaining independence, and you might think about other consideration. So what guidelines says, they recommend radical cystectomy plus minus neoadjuvant chemotherapy in muscle invasive bladder cancer, and trimodal therapy or partial cystectomy in selected case. And if you can't do these things, they say you can do TURBT alone, radiotherapy or chemotherapy. But what guidelines actually don't mention, there is no clear statement about elderly patients, comorbidities, quality of life concerns, expectation and functional limitations, surgeon experience, and medical support staff and services. So let's talk about life expectancy. Canadian statistics shows that at the age of 65, the life expectancy is 15 years. At the age of 75, it is 10 years. At the age of 85, it is 5 years. And this would be 2-3 years at the age of 95. There is no generally accepted age limit like prostate cancer and 10 years that we know and we discussed in bladder cancer. Like the consensus is about 2 years, basically because if you think that your patient doesn't live more than 2 years, probably he's not fit for surgery. What's going on the street? A good study by L. Gore et al. Looked at patients more than 65-year-old. They looked at SEERS database and then looked at the stage 2 muscle invasive bladder cancer between 1992 and 2002. Just 21% underwent radical cystectomy, and older age, having more comorbidities and long travel distance to the center, was reversely correlated with having cystectomy. And if you look at their table, it's interesting that 21% got radical cystectomy. In this group, just 18% of them were at the age of more than 80. So more prevalence in more than 80, but less treatment, less radical cystectomy. And if you look at their surveillance group, 1,600 patients, 1,000 of them were at the age of more than 80. The other work by Fedeli actually looked at all the age groups, 14,000 patients between 2003 and 2007. The proportion of patients with radical cystectomy is 42%, radiotherapy is 16%. So they found that age, being in the minority group, being uninsured and living in South or northeast of US and treated as a patient in non-teaching or research hospital is reversely correlated with getting cystectomy. And recently published paper by Gray looked at National Cancer Database treatments for muscle invasive bladder cancer between 2004 and basically 2009. 28,000 patients with a stage 2 and a stage 4. They excluded T4B. And if you look at their data, 41% actually treated with radical cystectomy, with or without chemotherapy, neoadjuvant or adjuvant. 3.7% had partial cystectomy and 7% had radiotherapy. Interestingly here, if you look at gray as if you look at brown as surgery and yellow as radiotherapy, you will see 60% of patients will be treated with definitive treatment if they are less than 50-year-old. But this number would be around 40% when they are more than 70, and would be around 30% when they are more than the age of 80. What about neoadjuvant chemotherapy? We know that there is level 1 evidence for neoadjuvant chemotherapy in bladder cancer, but if you look at the backup studies for that meta-analysis, you will see that median age in those trials were 63, 64, and 64. So I'm not sure if we can generalize their data to this group of patients. We need more trials. What about cystectomy? So the main concern when we hear about cystectomy and bladder cancer is, and elderly, is complications. So I remember when I was reading for the board exam, as per Campbell, it was between 20 to 40% rate of complication after cystectomy based on retrospective trials. But a very good study from Memorial actually shows that in a center of excellence, in prospective trials, 64% of patients, regardless of age, develop at least one complication within 90 days. So the concern is real concern. Very good review by famous people in bladder cancer looked at complication rates in the elderly. They say that it's very difficult to do this review because it's very heterogeneous studies, and you see that the age of patient as defined as elderly is different in different studies. Some consider 65, some consider 80, and the sample size also is different between 12 and 800. So they included 20 studies, and they found that 3 studies actually showed increased preoperative mortality in elderly patients. Also more blood transfusion or blood loss, probably because of our lower threshold to give the patient blood when he is older, or they are on more anticoagulation than the other group of patients. And we know that delirium is more common in this group of patients. 6 studies actually showed 5 to 20% chance of delirium after cystectomy. And the mortality is between 0 to 11%. But interestingly, if we define post-op course in 90 days as opposed to 30 days, it seems that it should be more accurate. To confirm this, a very good study by Quebec group, they looked at their cystectomy results retrospectively between 2000 and 2009. Interestingly, the complication rate overall was 2.8%. If you consider mortality in 30 days, it increased to 7% at 90 days. And in this group of patients more than 80-year-old, the mortality rate was 5.8%. It increased to 13%. So they had 1 out of 7 of their cystectomy deaths if the patient was more than the age of 80. And the complication rate was 30% as it is a retrospective trial. So what can we do to deal with these things? One thing is hospital and surgeon volume. It's not just because of surgeon, it could be because of like licensed practitioner nurses or respiratory therapists or other things that you have in the hospital. But the best definition for such a center is still unclear. What about ileal or ileal new bladder in this group of patients? We know that 70% of our patients get ileal conduit, but there are 2 studies by Clark and Sogmi looked at properly selected patients, center of excellence, they reported similar complication rates no matter what the diversion is. And then the idea of having retroperitoneal approach or extraperitoneal approach, doing cystectomy and ureterostomy, brought up by Brosi and Obrick in different papers in 2004, they said that you might have less complication if you do extraperitoneal approach. Interestingly, recently presented in EAU, Brosi again presented a very nice series, 170 patients, mean age of 83, ASA score, 44% ASA score 3, 23% ASA score 4, 64% non-confined disease, 21% positive lymph node. They did cutaneous ureterostomy in 2 out of 3 of their patients, 25% ileal conduit and orthotopic new bladder in 8%. So pre-op mortality was 7.6. Complication rate was 44%. Interestingly, in cutaneous ureterostomy, it was 26% versus 49% in conduit and 45% in new bladder. So it would be one thing to think about that. The other thing is that if you understand better the process of aging, we might have better results. So what is aging? Aging is heterogeneous process, characteristic universal changes in physiology affect each individual in different and unique pace, and it's basically depletion of your physiologic reserve. So when you are at the age of 30, your fuel is fully available, but at the age of 100, it's almost empty. So,
So you're looking at this, I'm just thinking about hip fractures in the elderly. That if they're over, as you take a general group, the 30-day mortality rate for hip fracture in the elderly is 7%. If they've got one medical problem, or they've got significant medical problem, it's 17%. If they've got pneumonia on top of the hip fracture, the 30-day mortality is up to 40%. So, you know, we're talking about 7%. We're doing a much more potentially invasive procedure on them. In terms of, you know, I think there's a lot of salvage that's going on post-operatively.
So we will talk about some of the predicting tools after cystectomy that if we can differentiate between those who are more prone to have complication as opposed to the other ones, and do cystectomy on those group and not in all patients. So I will talk about this.
Let's go back one slide. Yeah. Just want to see where I am in the gas tank. No, for the gas tank.
So as we talked, tools are available to identify older patients and the risk, and then for practical intervention. So we use tools to predict toxicity to cancer treatment, also predict survival for older patients, and also uncover the problems which are not detected by routine history and physical exam, and this leads to practical intervention. So we think that it is feasible to incorporate these tools into oncology practice. So based on the recommendation of International Society of Geriatric Oncology, we need to think about comprehensive geriatric assessments, including mini-mental status, depression, nutrition. Also, what is the difference between functional and chronological age, comorbidities, multidisciplinary care, and also we should expand the proportion of patients receiving 3-modal therapy, and we need better representation in clinical trials. So integrating geriatric into oncology is actually factors other than chronological age that predict morbidity and mortality in older patients. So by this, I mean we should think about the functional status, which you know it's ADL and IADL, which basically is if the patient is available, is suitable for like daily activity. Is he able to get dressed, take a shower, or use instruments like his financial things, or taking a bus, or cooking, or doing laundry. Comorbidities, we will talk about that. Nutritional status, is he able to swallow before surgery? Then you want to do cystectomy, put him on ERAS after and expect that he can eat. Or cognition, is he demented or not? Psychological status, is he depressed or not? If he's depressed, you do ileal new bladder and expect doing CIC for this patient after surgery. Social support, and then polypharmacy. So these are all geriatric assessment. I had an opportunity to be in geriatric ward for 2 weeks. It was very good experience. They use all of these things to assess the patient. So talk about comorbidities. So elderly patients have an average of 3 diseases: CAD, COPD, diabetes, hypertension. And interestingly, at the age of 75, 11% of community is actually demented. And it would be 53% when you look at the patient who live in long-term care facility. At the age of 85, it's 1 out of 3, and it could be 2 out of 3 when they are living in facility care. So you have 80-year-old patient, you want to think about cystectomy or other options. Which one do you treat? So if you look at their functional age, there is 30-year-old difference between these 2 gentlemen. So what we mean with geriatric assessment is that the patient come to geriatric doctor, and then they give them the tools, they work on the tools, and then they will sit and talk about morbidities, complications, options, and then it's very good way to facilitate the communication between patients and urologist, oncologist. So what tools we use, 2 more common of them are NSKIP calculator and Vanderbilt's nomogram. Interestingly, in NSKIP calculator, you will include age, sex, functional status, ASA score, steroid use, and ventilation status, diabetes, COPD, dyspnea, and then body weight and height. And then you might have 2 different patients, one with the serious complications rate of 17%, death rate of 1%, DVT risk of 4%, all below average. You will recommend cystectomy for this one. But this guy with a serious complication rate of 29%, any complication 43%, death rate of 6%, you probably do not recommend cystectomy for this. And if you use this nomogram, you will see they actually used age, comorbidities, muscle invasiveness, and total point. And then for this patient, it's 6%, for example. So if you don't recommend cystectomy, what would you do in muscle invasive bladder cancer? A very good review article published recently in European Urology. They actually concluded that a growing body of literature coming and suggests that trimodal therapy would be an option to have acceptable outcomes, and therefore considered as a reasonable treatment option in this group of patients. So basically, they give 40 gray to the area of bladder and lymph node to start. Then they boost the bladder with 54, and then boost the tumor with 60. So you can do maximal TUR, and then start chemotherapy, and then radiate patients, and then reassess the patient with cystoscopy, go for surveillance, or salvage cystectomy, which should be considered. So trimodal therapy is not doing cystectomy, is actually having cystectomy for the patients who don't respond to this trimodal therapy. But the problem of these trials are a low sample size, and then shorter period of follow-up as opposed to other data that we have for cystectomy. So if you want to use chemotherapy, then you should think about the eligibility for cisplatin as the main chemotherapy agent. And this is a good survey looking at the expert opinion of 120 oncologists. They actually said that they consider ECOG performance score of 2, creatinine clearance of 60, grade 2 hearing loss, grade 2 peripheral neuropathy, and NYHA class of 3 for heart failure. Although age is very important, but age alone should not be used to classify and fit patients in clinical trials. So if you want to do chemotherapy, you should think about renal function, cardiovascular function, neurologic system, hearing system, and bone marrow reserve. Interestingly, 50% of patients at the age of 60 to 69 actually, 50% of the patient more than 70-year-old actually has creatinine clearance of less than 50, which is important. But the other thing is about the creatinine. So if you look at the creatinine 1, 2, 3 in different age group, you will see that GFR would be 79 when the patient is 40-year-old. It is 32 when the patient is 100. So this is not an adequate measure of renal function. And you know that we use different formula. So Cockcroft actually commonly used, but not validated in older patients. MDRD is also good, but it's more accurate in patients with chronic renal disease. And Wright is more accurate in patients with better GFR. So none are perfect, but all are better than creatinine alone. So in the past, we actually considered patient age, ECOG performance, and labs, and then tumor characteristics to give or select the regimen. But these days, there are different tools. For example, one used by Huria actually looked at age, consider tumor characteristics, lab tests, and included 5 geriatric assessment variables before making decision for the patient. So considering falls, hearing loss, limited in walking, 1 block, assistance in medication, and then social activities. So then they score the patient to predict the chance of having grade 3 to 5 toxicity. So today, we use different models to predict chemotherapy toxicity and then to select the regimen. Different models, different things. So you will see that ADL and IDL actually considered in almost all of the methods or approaches. Hearing by Huria, nutrition in almost half of them, cognition in many of them, psychological status in some of them, and social activities in Huria model. So it's not just age and creatinine and performance status. And then you have some tools to calculate the risk by including age, BMI, creatinine, having your toxicity score, and then the risk of chemotherapy toxicity. So the other thing is that if you think about cisplatin, is there any alternative to treat the patient with other things if the patient is unfit? So with a study, EORTC study, looked at urothelial bladder cancer and then impaired renal function, performance status of 2. They randomized them to gemcitabine and carboplatin as opposed to methotrexate, carboplatin, vinblastine. They found that there is no difference in response rate, but less side effect in gemcitabine carboplatin group. And if the patient had a performance status of 2 and GFR less than 60, probably in 26% he experienced severe toxicity, but we need more clinical data. I want to read this slide for you. So this is NCCN guideline on palliative care. So the goal of palliative care is to anticipate, prevent, and reduce suffering and to support the best possible quality of life for patients and their families, regardless of the stage of the disease. And palliative care begins at the time of diagnosis. So it's not palliative care when we don't have any option. And it's not just for patient, it's for family as well. And it's to support them and reduce suffering. So looking at VGH experience, between 2006 and 2014, we had 510 cystectomies. Interestingly, 203 of them are over 70 and 52 of them are over 80. So we are dealing with all of these things in our daily practice. And one question at the end that no one knows why we age, and the upper limit of human lifespan is about 120 years, have not altered over the interval of recorded history despite advance in preventive healthcare and medicine. And the oldest living person with a valid birth certificate is or was a 122-year-old female, Jean Palmans from France, who was born in 1875 and died in 1997. So in summary, bladder cancer is primarily a disease in the elderly. Fast-growing segment of population is a fact. About half patients with muscle-invasive bladder cancer do not undergo radical therapy. This number increases with age. Most elderly patients should be eligible for radical cystectomy or three-modal therapy with acceptable outcomes. Presence of comorbidities and functional status may be more important factors than chronological age when determining optimal treatment strategies for elderly patients, and comprehensive geriatric assessment is a key point. I want to thank Dr. Black to help me with the slides and the comments, and also invite all of you to bladder cancer walk in this September and every September, either with your immediate family or extended family. Thanks.